Professor Ed Peile is going to talk about the patient's perspective and from his own experience, is that right, as being a patient? He is Emeritus Professor in Medical Education, University of Warwick, a fellow of 3 Royal Medical Colleges, and he used to actually be involved in postgraduate education at Oxford. So over to you, Ed.
Thank you very much. So yes, Rupal's already taken us into the patient's world. My task of hearing the patient voice in AI and enhanced healthcare caused me to think, well, perhaps I need to get up close and personal. So I'm going to talk about one patient's experience, which is my own. I'm going to try and broaden it out into some generalities using Jess's concepts embodied in the four Ps. But I think there is a place for N of 1 case histories, so let's give it a try. So my story started in 2021 when I began to have lower urinary tract symptoms. COVID type times, and I wasn't particularly worried about them. I was managing perfectly okay. I had no reason to worry. A couple of previous PSAs had been normal. So I went to look at my old and tried resources on LUTS, lower urinary tract symptoms in men, decided it wasn't very urgent, and then in June, I went to consult my GP, who dutifully, well, it wasn't I consulted online, and we decided I should have my PSA remeasured. And it was just at the upper margins of normal, nothing much to worry about. But she asked if I would like to see a consultant, and I said yes, I thought it might be a good idea to see a urologist. So that was how those decisions were made. Thinking about the 4 Ps, I think that there could have been a role for AI in prediction. That if instead of looking at my old and trusted resources, I'd tried to access some AI-guided resources, I might have got closer to predictive values as to when it's worth consulting. And I think there is a further role. I mean, there's a lot of work on prevention of prostate cancer going out now, but possibly there's scope for AI taking a greater role in looking at some of the more complex areas of lower urinary tract symptoms. So then I was referred, and the consultant reported that my prostate wasn't hard, like a malignant prostate, but it was a bit firmish. And that makes me wonder now about, can AI diagnostically cope with the issues? Because there are so many issues in medicine. The other thing I wonder about AI, my risk tolerance, like anybody else's, I suspect, is not only personal, but it's labile. Ask me about how far do I want to take this one day, and it might be different from how far I'd want to take it the next day. It's influenced by all sorts of things in my personal context. Anyway, we did decide to take it further, and so I had an MRI. And the MRI was quite definitive. The report came back essentially pretty well as bad as it could, that this is definitely prostate cancer. It's outside the capsule of the prostate. It's invaded the seminal vesicles. It's extensive throughout the pelvis, and they gave it the highest grade of an MRI on the prostate. So very definitive, but then a day later than the MRI came back the repeat of some urinary tests, simple urinary tests. They'd all proved negative on dipsticks, but they were showing a consistent E. coli. So the consultant surgeon said, we've got to think about this, could be a form of prostatitis. And so he went back. He had a bad experience because he'd biopsied someone with prostatitis and had putting his needle into an infected and had spread infection around, and the patient had died of septicemia. So I introduced the concept of, around that table of two, there are biases, as we've discussed, going on, and AI doesn't have the same biases, but has different biases. But how would AI cope with this spanner in the works of an infection there? And back to what you've all been saying about trust, and trust is what mattered. So when the consultant said, I don't think we should biopsy now, I don't think time is of the essence here, it's we should think about waiting. And we went back to the radiologist, who, he went back rather to the radiologist, who did indeed use AI and did find that, yes, that picture that she'd reported definitively as aggressive cancer could be caused by chronic prostatitis. So I throw that in just for what it's worth, and we moved forward. And so I agreed to a 2-month course of ciprofloxacin for my infection. I found ciprofloxacin in high dose for 2 months. I found it bloody awful. It's known to give muscle aches and pains. Walking is one of my joys in life, and I could hardly walk with the aches and pains of this. Might have been huge psychological overlay, but anyway, I was balancing fear against discomfort. And that makes me wonder about, I didn't know what mattered to me. I wrestle with this question of do I have to carry on taking it? Can I not cop out of it and so on? If I don't know what matters to me, how the hell can AI know what matters to me? So we went on and we went through it. I then did have a PSA PET scan, which showed no distant metastases, all to the good. And I had a transperineal biopsy, 26 cores, all of them showing the highest, or highest but one level of histological malignancy. So I, who've never scored very highly in all my life on tests, scored right at the top on that one. Then we came to the MDT, or rather, I didn't go to the MDT. I mean, in values-based practice, as those who will know, we talk about multidisciplinarity as so important, but I did feel my absence from the team of experts as they discussed all the results. But I did have good representation, I hope, from people there. But the report came back, and I quote, "The only sensible course is that surgery, it was not amenable to surgery, it was too extensive for surgery, so I should have high dose radiotherapy to prostate and pelvis." The phrase another phrase I liked was that despite the fact that the PET scan had shown no nodal involvement in the pelvis, the radiotherapy consultant said, well, micrometastases are inevitable, so we're going to blast everything in the pelvis. So would AI know that micrometastases are inevitable? Did he know rightly or did he know wrongly? There's all sorts of questions that come up because the difference between 37 days of having everything blasted in sight and the normal 7 days of prostate radiotherapy is fairly significant difference in patient terms. But I did trust the radiotherapist in the end. And the other thing they decided at that stage was to offer me abiraterone, which is not, it's only indicated on the NHS for sort of palliative care, improving quality of life at the end of care. But there'd just been a large trial which said that it could be extremely useful, could raise the prognosis from about half, a 50% chance of 6-year survival to by about 12%. And so on the basis of that, I went privately, was given this highly expensive drug, which included my improved my care. So lots of choices coming in there, and of course it had to be prescribed off-label in the results of the Stampede trial. So we came again to this business of what mattered to me, because the radiotherapist explained that it was helpful to have 3 or 4 months of the cytotoxic therapy before radiotherapy to shrink the prostate down. But we had long planned this lovely holiday in Lanzarote with our children and grandchildren, and that was important. And so I asked to extend the gap to 6 months before I started radiotherapy. It was explained the results weren't there to know about that, but I took the decision that mattered to me, and I took the decision on that one. So I've had my treatment. My radiotherapy was exhausting, but and caused a few problems, as we'll come to. But throughout, I have been extremely well served by the colleagues who've been looking after me. But then I came to the thinking about what Anne was saying about human beings are distractible, and how would AI cope? Because the adverse effects that I was encountering, there were a number of them, including, of course, several months of fecal and urinary incontinence, lymphedema in the legs, making my beloved walking difficult. All those were overcome. But two that I'd like to just mention, radiation proctitis causes bleeding from the back passage, and I had that came on late, but in 2023 I had 2 episodes of significant hemorrhage, and I was advised by the colorectal guys that I should have laser treatment to try and put a stop to that, argon therapy. But when we came to the business of side effects, well, yes, perforation happens in about 10%. About half of those are manageable conservatively, and that's great. But the other half, being so low and around this fragile area, I'm afraid it means a colostomy. And I'm afraid I balked at the idea of a 1 in 20 chance of needing a colostomy, and said, well, I think I'd rather soldier on. And to my nothing's right and nothing's wrong, but the last month I haven't seen any blood whatsoever. My blood counts have come back to normal, and I'm hoping that we're on top of it. But it is a decision that really does require human interaction as far as I'm concerned, because AI would definitely have recommended, I think it says I definitely recommend, but I think there's a high chance that it would have recommended the intervention because of the risk base on it. But the choice of whether to take that risk is a very, very personal one. My steroids that I had to have with the abiraterone caused me to get hypertensive. That was a blow to my self-esteem. I don't like to think of myself as hypertensive, but all of us have it. But my message there is just that minor things, insignificant things, can be uncomfortable for me personally. And the final one I wanted to mention was the risk of osteopenia, of thinning of the bones, because of my abiraterone and steroids. And the obvious thing is to go on medication, bisphosphonates. But again, one of their key side effects is muscle and joint aches and pains. And I am 1 in 10. And I said, do you know what? I'd rather wait, if I may, because I've only just got back to my walking, and to me it's important. Can we do a trade-off here? I'll start them in a year's time, if that's okay. And actually, I'm having my bisphosphonates now, and apart from the awkwardness of remaining vertical for half an hour on Sunday mornings, it's not a problem. But again, it was important to me personally to override the advice that was there, and I'm glad to say I have normal bone density. So basically, the adverse effects, they do happen, and that brought me back to thinking about the 4 Ps. Personalized AI. I hope I've given a personal picture of me as a one individual amongst millions, and AI will be extremely useful, but I don't think it can predict my values and choices, so I think it's got to interact with them. And finally, I think that what I take from here is I'm fully in support of participatory AI that can give us the information we need and frame our choices. Thank you.